you are applying cast as early as possible. Now that duration is, there is no such a specific guideline that it has to be treated from 7th day, 5th day, 10th day. It all depends upon the preference of the surgeon. All right. Why it should not be given right on the first day, right immediately after a birth? Because the skin of a child who is a newborn is too fragile to handle this plaster of Paris. So that is why it is delayed for some duration of time. But that duration of time could be 5 days, 7 days, 10 days and so on. All based upon the preference of the surgeon, treating surgeon. Like we are applying the first CTEV cast on 7th day of birth. Now, what is the difference in between the two? You know, in Kite's method, you are waiting for 3 months, while in case of Ponseti, you are taking up the charge and applying the cast as early as possible. So obviously, the better outcomes you can expect when you correct the deformity earlier in the age group of the child. That is point number 1. This is the reason why Ponseti method is a preferred method. Now, second one is that there is an order of correction in case of Kite's method. You know, when you apply the cast, you manipulate the deformities. You manipulate it by correcting the deformities. So first you have to correct the cavus. Second, you have to correct the forefoot, means adduction. Then the inversion, and finally the varus. So this is how the correction is achieved one by one of all the deformities. But in case of Ponseti, you are not correcting, or you are not focusing on the correction of a single deformity. You are correcting all the deformities simultaneously. And that is the reason why Ponseti method is considered to be a preferred method, because each and every deformity is directly or indirectly related to the other deformities. When you are correcting the equinus deformity as well as the forefoot adduction deformities, that means you are correcting the entire deformity, range of deformity of the foot. And this is why Ponseti method is having a better outcome in comparison to the Kite's method. And this is the reason why Ponseti method is considered to be a preferred method. All right. So this is how, these are the basic differences in between the two. So let's now imagine that the child is now having the foot over corrected. Now the over correction is achieved. Now after achieving over correction, what do you mean by the term over correction? That means the equinus is getting converted into dorsiflexion, the inversion converted into eversion, forefoot adduction is converted into abduction. All right. So you have over corrected the deformity. So once you have over corrected the deformity by, for example, after the application of 8 cast, after the application of 9 cast, this over correction is achieved. Now what has needed to be done? You know, after achieving over correction, in order to prevent the recurrence of the deformity, just to prevent the recurrence of the deformity, this over corrected foot is kept in a splint. So DB, that means Dennis Brown splint is, or Dennis Brown splint is placed over the feet of the child. But you know, apart from this, remembering this DB splint, you also need to remember the other name of this splint, and that other splint is SFAB, that is Steenbeck foot abduction brace. So once the overcorrection is achieved, in order to prevent the recurrence of the deformity, it has to be kept in these splints, that is DB splint or SFAB. You know, DB splint is something that you already might have heard about, because it is considered to be the most commonly used splint. But nowadays, with the slightest amount of the modification, this DB splint is getting converted into SFAB with slight modifications. We are going to have a discussion on that. But at this point of time, you just need to remember about these two splints, the name. And remember, these two splints are not used to correct the deformity. They are just used to prevent the recurrence of the deformity. Write it down. It is important that they are used to prevent the recurrence of deformities. All right. They are used to prevent the recurrence of the deformities. Okay. So the next question is that for what duration of time this DB splint has to be applied, all right, or till what age group this DB splint has to be applied, because you have started the management since the birth of the child. Imagine after 2 months of age, all these things got overcorrected. Now this DB splint or SFAB has to be used till what age and for what duration in a particular day. So this DB splint has to be applied for around 23 hours per day till 1 year of age. That means the walking age. All right. So this DB splint has to be applied for the period of 23 hours per day. You know, it is just considered to be a rough estimate. That means it has to be applied almost for an entire day. It should be applied for the entire day. You know, 1 of the hour is going to be wasted if you are if you are keeping a child on massages, if you are bathing the child. So if you are taking care or if you are clothing the child, so in that case 1 hour is going to be wasted. But apart from this, it is recommended time duration is around 23 hours per day for the period of 1 year of age. Now, why till 1 year of age? Why not beyond 1 year of age? Because at 1 year of age, most of the child, they starts walking. And when the child starts walking, that DB splint has to be replaced by a CTEV shoe. All right. So in a walking child, next segment of the section is that in a walking child, when the child starts walking, this splint is replaced by CTEV shoe. Now this CTEV shoe is not something which is very different. CTEV shoe simply means identification based upon to prevent the recurrence. So what are going to be the specificities in this CTEV shoe? What all is going to be there in case of a CTEV shoe? You know, in CTEV shoe, or how will you identify a CTEV shoe? Point number 1, there will be no heel. So why there is a provision of no heel? Just imagine, if you provide a heel, then the foot will be placed in slight amount of plantar flexion and there will be a possibility of recurrence of the equinus. So to prevent equinus, there will be no provision of heel. So no heel to prevent equinus. Point number 2, that there will be straight medial border of the shoe. You know, this is the shoe. Most of the time what we are having a this kind of a prominent inner border of the shoe at the point of the great toe in order to accommodate the head of the metatarsals. But if you provide this kind of the prominence over the inner aspect of the shoe, in case of a CTEV child, then the possibility of forefoot reduction will be there. So to prevent the recurrence of a forefoot reduction, there has to be a straight medial border. It is kept straight in order to prevent. So it is to prevent adduction of the foot. All right. So to prevent the recurrence of the adduction. And finally, in order to prevent the inversion of the foot has to be kept everted, and that everted position is achieved by raising the outer sole of the foot. So raised outer sole. So these are the 3 modifications on the basis of which you will identify that the shoe you are watching is actually a CTEV shoe. So there will be a raised outer sole to prevent inversion of the foot. All right. So this is all what you need to remember. And the timing for the CTEV shoe to be kept inside a child to prevent the recurrence is around 5 to 7 years of age. So CTEV shoe has to be continued till the age of 5 to 7 years of age. All right. This is how the management of CTEV goes on. So hopefully you have understood everything related to the management of the CTEV in case of a newborn. If a child is diagnosed as well as managed right from the birth of the child. So again, quickly, if a child is born with the CTEV deformity, it is clinically apparent, you will subject a child to an orthopedic surgeon. An orthopedic surgeon will decide that when to apply the first cast, either immediately or after some duration of time. Now, that Ponseti method is a preferred method. You already came to know the differences in between the kite and the Ponseti method. So you will continue with the Ponseti method. There will be a serial correction of all the deformity by the application of Ponseti casts. When all the deformities are getting overcorrected, you will put a CTEV splint, that is either a DB splint or a SFAB, for the period of 1 year of age in order to prevent the recurrence. Once the child starts walking, then that splint is going to be replaced by a CTEV shoe. Again, the indication of CTEV shoe is simple, to prevent the recurrence of the deformity. All right. So this is how it is managed. Now, what all for a child who is coming at 1 year of age? Now, as I told you, that there could also be a possibility when the child or when these kind of a children are coming at various age groups. Now imagine if a child with the CTEV is coming at 1 year of age. All right. Now what could be the reason for this child to come at 1 year of age? Either they are coming with the neglected CTEV. You know what happens, that if a parent in a remote rural area is having a child who is having CTEV, then they wait that possibly that the child when starts walking, there will be a correction of this deformity. All right. So this comes under the category of neglection. So it is a neglected CTEV. Or the second possibility is recurrent CTEV, that the deformities were corrected, but now they are getting more and more recurrent. All right. So at 1 year of age, what would be the management? Management will remain the same. That is Ponseti method. So it is not actually at 1 year of age. The first thing that you have to go for, it is actually for 1 to 3 years of age. That means from 1 up to 3 years of age, if a child is coming to you with this CTEV deformity, then instead of going for the surgical corrective method, you have to correct it by conservative method. That means serial correction by Ponseti method. All right. If it fails, then you can go for the surgical corrections. So what if the child is coming in 3 to 5 years of age? Imagine if the child is coming to you with in this age group of 3 to 5 years, then the correction can never be achieved by Ponseti method. It is difficult to achieve the correction by Ponseti method because the failure, incidence of the failure, the chances of the failure or the chances of recurrence are too high. In order to prevent it, you have to go for surgical correction. That surgical correction, bone disturbance is not required. Bone osteotomy is not required. Just by relieving some of the soft tissues, you can correct the deformity. So what are those segmental soft tissues which are needed to be sectioned in order to correct the deformity? Obviously, it is going to be the PMSTR. That means posteromedial soft tissue release. Why postero? Because the patient is having a equinus deformity. So the posterior tendons are needed to be sectioned. The Achilles tendon is required to be sectioned. The flexor hallucis tendon are required to be sectioned. All right. Similarly, the medial tendons, which are responsible for forefoot adduction as well as inversion deformity, they are needed to be sectioned in order to correct the deformity. So posteromedial soft tissue release. All right. This is how in a child of 3 to 5 years of age, the CTEV deformity is more likely to get corrected. But what about those children who are landing up in the age group of 5 to 8 years? Now imagine there comes a child who is having a neglected CTEV in the age group of 5 to 8 years of age. Then in that case, just by sectioning or just by releasing these soft tissue won't correct all the deformities. In that case, the bone osteotomy is required. And you know, majority of the osteotomies are confined at the calcaneocuboid junction because it is the lateral aspect of the foot which is needed to be osteotomized in order to correct all the deformities. All right. So as far as the names of these deformities or the name of the osteotomies are concerned, like there will be DWYER, Dowers osteotomy, corrective osteotomy, then Dillwyn-Evan procedure, as well as Lisch-Blau procedure. Now all these procedures are confined at the correction or performing the osteotomy on the lateral aspect of the foot, that is calcaneocuboid. So all of them are actually involving the calcaneocuboid osteotomy in order to correct all the deformities. All right. So for 5 to 8 years of age. Now what about those children who are having beyond 8 years of age? That means 8 to 10 years of age. Imagine if a child is coming to you with the CTEV deformity when the child is in the age group of around 8 to 10 years, then the correction by performing these osteotomies also cannot be achieved. In that case, the arthrodesis, that means triple arthrodesis is required. Triple arthrodesis.